what we anticipate the mental health response to be as part of the COVID-19 pandemic. So with my colleagues Peter Hughes and Ian Petch, we're going to share with you some of the data and some of the things that we're predicting may happen as a result of the COVID-19 pandemic, and how we can best come together as a community to support each other and those with mental health difficulties during this time. I hope that you'll find the next 10 minutes an interesting watch.
My name is Dr. Peter Hughes, consultant psychiatrist here in the South West London Trust, and I'm here along with my colleague Ian Petch, and our topic to discussing is collective trauma.
Thank you, Peter. And my name is Dr. Ian Petch. I'm a consultant clinical psychologist and the head of psychology and psychotherapies at the Mental Health Trust. And we've been asked to talk to you briefly today about the mental health needs of people as a result of COVID-19. I'm just going to move to the other side of the screen, and because we're socially distanced, I'm going to take my mask off. So we're going to talk to you this afternoon about 6 key actions that we think are important in the management of the mental health needs that arise as a result of COVID-19. We need to keep our mental health services open and easily accessible to people. We need to continue to plan for surges in demand, that's already well underway, and we need to work closely with our primary care colleagues, because that's where the majority of people with mental health needs are seen and will continue to be seen. And primary care does a great job of delivering high quality mental health care. 3 other key messages we want to convey. Within our communities, there are people who are more vulnerable than others, and we should prioritise those people. We should also strengthen families, workplaces and communities, because that's where people will experience safe, trusting, supportive help, and that's where most of us turn when we're feeling stressed. And finally, one of the most important buffers against any form of stress is making sure people's basic needs are met. So, how do we begin to think about the mental health needs that arise as a result of COVID-19? It's a bit of a complicated chart, but essentially what it is saying is there may be a bit of an increase in demand as people begin to step forward again and contact our services for help. People who've refrained, they've held back from seeing us because of the lockdown that was imposed back around March 2020. And then we also need to think about the need that specifically arises directly or indirectly as a result of COVID. This is new cases of mental health problems. So we've very much given a message that our mental health services are open. We've collaborated with our local commissioners using social media and other forms of media to make sure the public know that we are open. We have been checking on recently discharged patients to make sure that if they need additional support, they do come back to us. And we've made some very specific adaptations, like the Orchid Emergency Unit, where emergency psychiatric assessments can be obtained rather than patients having to go to accident and emergency. And the question is, has that worked? Well, as a couple of illustrations here of referrals to our early intervention teams on the left-hand side, and our referrals of people with depression and anxiety to our primary care psychology services, we can see that around March 2020, a big dip in referrals, followed by a steady increase in referrals, so that they are more or less back to the levels of referral that we saw before the first lockdown in 2020. So that it appears that people are now stepping forward and seeing us. I'm going to whiz through some of this other data here. What about the new need? People with mental health problems as a result of COVID-19. We need to think about specific populations. People with existing mental health problems, it's thought that about 1/3 of those will experience further problems with anxiety and depression and need to see us for those difficulties. And then there are general population without any existing mental health problems. Complicated chart, but it's essentially saying around 4, 5, 6% increase in the current referrals to our services of people with depression and anxiety. We need to think about our healthcare workers, where we will see some increase in PTSD and what's described as high psychological distress. Somewhere between 3 and 10% of those workers may want to come and see our mental health services. We need to think about people who are recovering from severe COVID-19. It is expected we will see more people with depression, anxiety and PTSD. Somewhere between 6 and 10% of those people will need to see us. It's important to remember while we look at these figures, this is not 6% of the general population, this is 6% of people recovering from severe COVID. There are also people who are bereaved, where we expect to see some unusual or some abnormal grief reactions like prolonged grief disorder or traumatic grief, a form of PTSD. But again, somewhere between sort of 2.5 to 3.5% of people in that group might come forward and see our mental health services, although there will be a larger percentage of people in this bereaved group with those problems. Only about a third of those will want to come and see us. And then there are those people who have lost their jobs, lost their income as a result of COVID, where we expect to see about an 8% increase in depression, and around 2% of that group we think will want to come and see us for help. What we know is people are worried too. This is some data from a large-scale study conducted by UCL. It's an ongoing study, and I'm not going to dwell on the details of this other than to say people are anxious about things like catching COVID, losing their income, losing their job and getting enough food, but this isn't equally distributed across the general population. When we look at particular effects like depression, we can see here that top line are rates of depression being reported by people who already have a mental health problem. The blue line is level of depression being reported by people without an existing mental health problem. Key message here, there are more vulnerable people in our local communities, and those vulnerable people are those with a mental health problem, those with physical health problems, those living alone, those on low incomes, those living with children, people in the 18 to 29-year-old group, and people of Black, Asian and minority ethnic origin. And the message here is those are the people we particularly need to pay attention to in our local communities. In amongst those people, there'll be a larger population of people who are distressed, who are worried, who are feeling fed up, but we don't want to medicalise that. What about trauma? We will see some PTSD, but it's most likely to be amongst healthcare workers working in ICU, patients themselves who've been in ICU with COVID and survived, and people who are bereaved. Just to illustrate what we might be looking at here, this is a study from 2017, large-scale World Health Organization study, 51,000 people, 70% of whom said they had experienced a traumatic event. 40% of those traumatic events were actually things that happened to other people, like the unexpected death of a loved one, kinds of things we'll see in COVID. But only 4% of this group of people actually developed PTSD. What this is telling us is lots of people are exposed to trauma, but a very small minority of those people go on to develop PTSD. Some other data here that suggests exactly that same picture. What is the message? We can see that most people affected adversely by COVID are going to fall into what we call a category of normal distress, where the help and support they need will come from friends, family, faith groups, local community groups, workplace colleagues. Safe, supportive, trusting relationships. We'll see a smaller increase in problems like domestic violence, substance misuse, depression and anxiety, Now, mental health services are preparing for those increases through surge planning, and then we'll see a proportionate, smaller increase in severe mental health problems, including things like PTSD. At this point, I'm going to ask my colleague Peter to talk about his experience of working with large-scale events like pandemics.
Okay, well, I'm going to speak as a clinician working here in the Trust, working on a COVID and assessment testing ward. So we're seeing COVID cases all the time. Also speaking as a humanitarian expert, working in the humanitarian field for about 15 years, and I've worked in various natural disasters. When COVID happened last year in 2020, people were saying, well, we've never come across anything like this. So the Trust asked me to be an advisor on this, as I had dealt with the Ebola response in West Africa. I was asked by WHO to be one of the people leading on the psychosocial response to Ebola at that time. And now I'm doing some more work with WHO at the moment, Geneva, on COVID response. So firstly, I'd like to say kind of what we're seeing right now at the moment. And speaking as a clinician, I can say I've just come straight from my wards now. We're seeing people with depression, anxiety, substance abuse, suicidal thoughts. We're seeing domestic violence. We're seeing increase of problems with children. This is kind of exactly what we'd expect. But overall, I think the message that we see here and also in Sierra Leone and West Africa at the time of Ebola is the resilience. So although we talk about collective trauma, the message I really want to say is that people have great resilience, and trauma may not be the exact right word, because trauma sort of implies that people are unwell, they've got mental illness, it pathologizes what is normal stress and a normal distress to have in these contexts. So what can we do from now? I think thinking about this as a community stress. For me, in the humanitarian world, we wouldn't use the word collective trauma. It wouldn't quite fit in with what we would say, but we would talk about stress and community stress. We would talk about the need to deal with people's basic needs. This is really, really important. That's what all the humanitarian emergencies I go to, people are asking about their daily basic needs. And how do we deal with this? Well, we use tools like psychological first aid, which has been used in this country as well, which is a way of dealing with people in distress, giving them messages of hope, dealing with their basic needs, and being supportive. The other things that are really important are when people are not managing, when they're overwhelmed, then we refer on to people like myself, like Ian, in the specialist services to deal with specialist problems. Other areas that are really important are self-care for all of us, whether we're working in the health sector or social services or the general community, how we manage our own stress. Other things that we need to think about how we deal with how we deal with this is kind of attending for vaccines, wearing our masks and social distancing. So overall, I would say, just as we had in West Africa, we had healing dialogues, or some form of symbolic event which is kind of forward-looking, rather than defining ourselves by this stressful event. I'm handing you over now to my colleague Ian.
Thank you, Peter. So I think in summary, what we're saying is the specialist mental health services, the primary care mental health services, very much remain open. We're planning for a possible increase in demand for our services, the true extent of which we won't really see until the pandemic is over. But we also really want to convey the message that the majority of support that people need and will benefit from comes from our local communities, our families, our colleagues in our workplaces. We are already working with a range of community and voluntary services. There is planning underway to increase the capacity within the community to support people who are bereaved as a result of COVID. We're part of a large initiative called South London Listens, talking with a range of community and voluntary services about how they and their members can support members of the public who are distressed, stressed, unhappy, uncertain about the future. So we may not use the term collective trauma, but we are certainly talking about a collective effort to support people who are struggling at the moment. At the same time, our specialist mental health services very much remain open for those people who have formal mental health problems and need treatment for those things. We hope this has been a useful summary of what we expect to happen in relation to mental health needs as a result of COVID. Thank you for listening to us.